Thank you so much for joining us on At Issue. I'm H. Wayne Wilson, and we're glad you've joined us for a conversation about the future of medical care in Central Illinois. Yes, we're going to talk about the Affordable Care Act. Some of you know it as Obamacare. We're going to talk about the state of Illinois' requirements and where medicine, specifically where hospitals, are changing to provide care in the future. And to have that conversation, we have leaders from the three hospitals. We have from Methodist Medical Center, Dr. Keith Knepp. Dr. Knepp is the Vice President and Chief Medical Information Officer at Methodist Medical Center. Thank you for being here, Doctor.
It's good to be here.
Across the way, Dr. Steve Hippler. Dr. Hippler is Vice President of Quality and Clinical Programs at OSF Medical Center. Thank you for joining us.
My pleasure, H.
And the President of Advocate Bro-Men Medical Center in Bloomington Normal, Colleen Canaday, is also here. So we're going to go to the top in management to find out where they think medical care is going. In talking about this prior to the taping, we're not quite sure, are we? Let's start with, can you define the overall impact that the Affordable Care Act will have on delivery of services by a hospital? Is there any way to do that in short form? Or an example of what it might do? Any guesses? Because I think that's what we're talking about.
That is a tall order. It's very broad. As we talked about before, one of the changes that will come with the Affordable Care Act is going to be a requirement and an opportunity for hospitals and health systems to focus beyond just the acute care setting and to really start engaging in managing populations and focusing on wellness and prevention and disease care in ways that we haven't been able to in the past. So it broadens the work that we do outside of just the hospital setting.
Yeah, I would agree. Hospitals are going to remain acute care facilities, taking care of all the acute care needs in our communities, stroke care, heart attack care. But what the Affordable Care Act really does is broaden the responsibility of integrated health delivery systems so that hospitals won't just take care of acute care. We need broader systems, including physicians in their offices and community partners, to really focus more so on the health of our community, the health of our patients, and the wellness of the patients that we see. So hospitals, H, I think you'll see still performing the same critical function that they perform in their communities, but with a greater emphasis around them on providing better health, better care, and preventive care.
And I would agree with that. And I would also add, just like the name, we become accountable, and it's really focusing on care across the continuum and managing the care of a population. And so with that, I think, comes some exciting opportunities in really looking at new partnerships, not only with the physicians, but with your post-acute care providers, so how we partner with our home health, how we partner with skilled nursing facilities, really looking to manage the care of the patient across the full continuum.
And I'm going to extend on that even a little bit further. I think it's also, how do we partner with our communities and our community agencies? That, you know, a lot of what we see in our hospitals and our emergency rooms around health issues really are more psychosocial issues, issues of poverty, poor education, poor health navigation. So I think what's going to happen in the future, H, is that we need to partner with our schools, partner with our churches, partner with other healthcare providers in our communities, our businesses, around how do we address the really common societal problems that we're facing around obesity, smoking, poor diet, lack of exercise. I think what the Affordable Care Act does is, as Colleen mentioned, makes us more accountable for the health and well-being of our communities, which I think is going to drive a completely different strategy around partnering with our communities.
Dr. Knepp, can you guess, and I use that term specifically, can you guess at what that might mean for you when you go out and you partner and you try to address areas that you really haven't had to address in the past, such as how do you prevent obesity, or how do you stop people from smoking?
I think Dr. Hippler made a great point on that, which is we actually have been trying to work on this for a long time. You know, both of us being primary care physicians, it's been a focus of our work to try to work with our patients to improve their nutrition, their exercise levels, to help them stop smoking. But the amount of time that we have with a patient in the course of their hours and days in a typical year is so limited that we can only influence a small part of that. So it does require partnerships and working as a community to address some of those things. And maybe that's working with employers, helping them to change benefit structures on their insurance plans to incentivize people to stop smoking and to participate in wellness programs. Maybe it's partnering with schools. Maybe it's partnering with churches to help provide a safety net that we just can't do on our own.
But I think that is a portion that becomes very, I think, overwhelming as you look at the responsibility of where we are in healthcare. And on the provider side, the hospital side, it's kind of like thinking, how do you solve world hunger? And you've got to, it gets back to the community partnerships, and how do you break it down into components or segments or opportunities to really impact portions of your community by coming together in broader partnerships. And I think that's the part that is really exciting when you look at where we can go in working together, and we're stronger coming together rather than necessarily just competing or focusing on just patients when they're sick.
Yeah, I think our acute care facilities and our hospitals have had what I'll call subject matter experts. We've had the expertise in a lot of these areas, but we've not had, as Dr. Knepp mentioned, the ability to really touch patients and our communities in multiple different areas. So I think the strategy has to be is how do we lend our expertise to community efforts around finding those food deserts in our communities, finding where the psychosocial issues are the greatest in our communities, and partnering with others who can help deliver that with us.
Can you give me some examples of how you're reaching out? I know Methodist is the opportunity to actually be involved in the community learning centers. The new schools have been built in Peoria. Now that's beyond students, isn't it?
It is. It's primarily focused on students, and it's an opportunity in two ways. It's a way to deliver appropriate care for acute illnesses that come up in the school setting and give access to students that might not otherwise be able to get health care that they need. But then there's the focus on obesity, nutrition choices, exercise, other things that school program gives us an opportunity to reach out into the community in ways that we couldn't before.
You're shaking your head. You have examples?
I do. You know, at Advocate Broman, we this past year partnered with the American Heart Association, very focused, a couple of things. One, starting walking paths within the community to encourage people to get out and get walking. The other part was partnering with one of our elementary schools in the community to start a teaching garden where the students actually planted fruits and vegetables in a garden, had the opportunity to learn about nutrition, and at the end were able to harvest those vegetables and the fruits and be able to both eat them and take them home with some very healthy recipes.
Yeah, how great. You know, we've also for years had a parish nurse program where we have nurses in multiple parishes doing wellness days, healthcare screenings, and providing a resource for members of the parish. But we've also taken upon an effort to do advanced care planning. And developing multiple facilitators in our community, patterned after what's been done in La Crosse, Wisconsin, to start having some of those critical conversations with patients about what their wishes are and what they want, what type of health care they want as they get older and may not be able to speak for themselves.
So far, we've been talking about some positive things that the Affordable Care Act may not even have been necessary. You want to reach out to the community. You want to have partnerships. You want to provide preventive as well as reactive care. Let's talk about the difficult part, and that is the financing of all this. How does a hospital, a medical center, go about balancing? And let's start with for instance, we know that Medicare and Medicaid pays less than the cost of delivery of care. We know that that's made up in part by commercial insurance, that commercial insurance is paying just a little bit more than the delivery of care. But as we look at the overall requirements of the state of Illinois and the Affordable Care Act, it's going to be more and more difficult for medical centers to maintain that balance. How does Broman go about handling this?
Well, I think it's not just a local issue. This is a national issue that every healthcare delivery system is looking at as we continue to see pretty widespread reductions in terms of Medicaid, Medicare, that we're all looking at ways to be able to do more with less. And I think, you know, a number of things. We're all focusing on innovation, Lean, Six Sigma. I think another area that you're really seeing, in order to be able to bring the costs out of the delivery system, you are continuing to see consolidation and smaller independent hospitals becoming parts of larger systems in order to take advantage of those economies of scale, because that is going to be, it's an important element going forward and really an opportunity to be able to capitalize on size.
I think another opportunity we have today that we didn't have in the HMO era of the past is we now have good information about a lot of our patients. We know that somewhere between 5 and 10% of patients consume about 50 to 60% of healthcare resources. So now with
Say that number again?
Yeah, about, if you look at a Medicare population, about only 10% of that population consumes about 50 to 60% of healthcare resources. So, you know, part of the work we're doing around the Pioneer Accountable Care program is to identify those patients and understand who they are and give them more care, give them extra care, give them the services of a dedicated care manager and care coordinator to really understand what are their barriers to care. Is it affording medication? Is it psychosocial issues? As we've done this, we've found a lot of non-medical reasons that needed to be addressed in order to help these patients and help their families and prevent their emergency room visits and prevent their hospitalizations. You know, I think one of the promises I'm hoping that will be realized in the future is that by really being able now to focus on people who are at higher risk, in addition to our whole community, we can keep these people healthier and lower the cost of care that we all as a nation are faced with dealing with.
Let me talk about one aspect that I'm under the impression it's going to help in delivery of care, and that's electronic records. Soon, and Quality Quest for Health has the Central Illinois Health Information Exchange, which will be part of all this. But if someone has services at either OSF or Methodist and then ends up at BroMen, for instance, you want your doctors and nurses to have immediate access to that information. That's a good thing, right?
That's excellent.
And that builds on what Dr. Hippler mentioned about information. He mentioned we have more information about our patients. That really means we're storing our information about our patients in better ways to allow us to work together to take care of them. So we have information in our record and information in other records that we can all share, so that those silos of I'm seen in the office versus I'm seen in the hospital can go away, and we can work together better.
And it helps us reduce waste. So if somebody had an MRI scan last week, it's not repeated just because information is partitioned and siloed in different health systems. It'll help us reduce some of those costs in our healthcare system as well.
Is there a cost associated with making this transition? There has to be.
Absolutely.
Sure.
Yeah.
And one that you will have to absorb.
That's true. We are getting some reimbursement through the stimulus bill that was passed actually before the Affordable Care Act, which gives some reimbursement to hospitals and physicians for use of electronic health records. And that's been a mixed blessing. It has brought some revenue to help recoup some of the investment we've made in electronic health records. It's also added new requirements, which sometimes are hurdles to jump. And so it's been a mixed blessing for us, but it is a significant investment.
I was just going to add, I think, you know, there are components of this that we've been talking about that really create for a better system at the end of the day for the patient. And I think the another component of it is, you know, we are now aligning in many ways the incentives of the physicians, the hospitals, even the payers to come together to really focus on health, wellness, and care across the continuum versus just fragmented care, and that includes incorporating information systems where we can share the care of the patient and what's taken place.
You You know, another important aspect of electronic health records that we've not mentioned is our patient portals. I believe we all, as part of our electronic health record, have patient portals where patients now have the ability to sign on through their computer or their iPhone or their iPad to get information from their health record, to help really engage them more in their care, to where patients can make an appointment on the internet. I mean, it's been a long time since I bet a lot of us called a travel agent or called an airline to get a reservation for an airline. Well, you know, part of the movement to electronic health records is to get us up to speed with a more consumer-friendly electronic ability for patients to access their health record, to make an appointment, to send emails to their providers, to really engage them more. Because the changes that are occurring are more than just what has to occur on a healthcare delivery side. It really is engaging our patients and community more into the care.
What I'm hearing throughout this conversation so far, it all seems to come back to hospitals cannot do this alone. You're going to have to somehow, and I'll use your word, engage me, the patient, and maybe patient isn't even the right word anymore. How do you go about that? How do you say, H, you need to go out and bicycle or walk or whatever it is, and you need to lose weight? I don't, but you need to lose weight or quit smoking. How do you, and I know partnerships with different organizations, but still we are individuals and you can only do so much. And then when I, being overweight, have diabetes, I come to you and say, Doc, fix me. I messed around for my whole life, now fix me.
You know, I think part of that discussion is happening with employers as you look at their rising cost of their healthcare premiums to provide coverage for their employees. You mentioned smoking cessation and things that they're doing as employers to incentivize their workforce to become healthier. And I think that's going to become an increasingly important component. The other thing is, you know, as we look at the model of healthcare and really focusing on primary care physicians. You mentioned case managers in the primary care physician practices. They are proactively reaching out to the patients to encourage them to monitor their health, to stay healthy, to incorporate, are they taking their medication? Are they monitoring their blood pressure? Those kinds of things. It's connecting with the patient where they need to be reached in order to make sure they're doing what they need to do to stay healthy.
And a large part of the Affordable Care Act is providing the opportunity to have insurance to the uninsured. So I think we'll see a lot of benefit come from having patients who had not previously had insurance or had a relationship with a primary care provider, now having access to a wider, more expanded primary care base in all of our communities, with all these services available behind a primary care practice.
Will that reduce the load on emergency departments?
It could potentially. I think that's to be determined, and this expansion of access will only reduce the emergency department load if we have the capacity to take on those patients and manage them well in our primary care practices. So that's the goal going forward.
Because I think what you see now in emergency rooms is a lot of things that are in the emergency room aren't really truly emergencies. It's become just the practice location of default almost for people who have no insurance or can't get care today anywhere else, or who may have psychosocial issues or other issues preventing them from getting care. The emergency room now is more than just emergency issues. So, you know, we really need to find other ways to care for primary care issues outside of the emergency room setting.
And I think you're seeing many of the primary care physicians and the practices respond to that. It's about increased access, so we're looking at, the physicians are looking at how do I have early morning appointments before work, how do I stay open later in the evening, Saturday appointments, and also really going towards, you know, same day appointments. If you call and you need to get in that day, the physicians need to be able to find a way to accommodate that, or they end up in the emergency department.
And one of the things we haven't talked about, which I think is critical to mention, is people ask me, well, what's different about this round of healthcare reform than HMOs, right? So we've done this before, we've gone down this path of managing care and it didn't work out so well. And there's probably several differences, but one of the big ones from where I sit in a primary care perspective is the first time around we really did not invest in the infrastructure that it takes to provide what patients need in their general internal medicine practice, their family medicine practice, or their pediatrician's office. We made those physicians responsible for managing utilization and decreasing referrals, but we didn't give them any more resources to do that. And now this idea of putting case managers in a practice to help those patients that have extra needs, investing more up front so that physicians have time to get those patients in when they're sick and they don't have to go to the emergency department, that investment in that upfront piece has to come for this to work. And I think it is, but that's a big piece of this that we can't lose track of.
Let's bring the state of Illinois into this conversation. The state, obviously under financial constraints, has limited dental offerings, has eliminated Illinois Cares RX, has in some cases limited the number of prescription drugs to 4. What's the impact on hospitals with all that? And I haven't even touched late payment. But
I really worry about some of these limits, not just on hospitals, but on the hospital system and really the state of Illinois as a whole. You know, I think I read the estimate was there was only about 18% of patients in Illinois who had 4 or more prescription drugs. But yet these represent typically the sickest patients. And the big issue in any population is patients getting their medicines and taking it correctly. And as we start limiting the number of prescriptions that patients can have, especially those that may not have the ability to pay out of pocket, I really worry that what we're going to see is patients not taking medicines that they should and showing up in our emergency rooms and hospitals, leading to poor health outcomes in those patients and a greater cost for the state of Illinois as a whole. I worry about that initiative in particular.
And the bottom line at Advocate Bro-Men, they're not reimbursing as much as they used to?
Well, no, that's an issue, and I think the other part that you mentioned is the payment delays, that the state is out about 360 days plus in terms of payment and what's out there in accounts receivable, and that's putting a strain on many hospitals in terms of cash flow. Again, it goes back to one of the benefits of being a part of a system is that you can weather that. I think the other part I want to just highlight, going back to the state of Illinois, and one of the challenges we face is really the issue of mental illness. And when you look at the fact that as a state, during all of the cuts that have taken place the last several years, so much of what's been cut has been care for the mentally ill, especially treating in the outpatient setting. And so we are continuing to see such an increased burden in our society being placed on hospitals, those patients showing up in the emergency room, and first responders, police, struggling with how do we deal with this issue in our community?
We very much live that every day. I mean, that's right. I'm so glad you brought that up. It's really a system that was strained before and is in a critical point now, and just in terms of access for those higher level services that mental health patients need.
You know, Methodist took the baton and ran with it when Zeller was closed and said, we're going to provide to the best of your ability mental health services for both adolescents and adults. And that is unique in this area. Are we going to see more of that kind of where we don't see competition? Because right now, you know, Methodist has tomotherapy and you have Trilogy, and I'm sorry, I don't know what kind of radiation treatment you provide, but you're all competing with one another. Hey, we've got this. Are we going to see, because of these financial constraints, that OSF is the hospital of choice for this particular service, Methodist for this particular service, Advocate Bro-Men for this particular service? Is that so you won't be providing certain arenas and you'll say go to OSF?
So I think on the psychiatric side, I think that's a broader, just to close the loop on that, that's a broader society issue that we've got to find a way as a nation and as a state to be able to deal with, because so many of the patients that end up both in the emergency department admitted to have other needs outside of true healthcare needs. But to your point, I think, as we look at where we're going with healthcare reform, in many ways, as we become accountable for keeping patients healthy, well, out of the hospital, those services you've just described actually become cost centers to the hospitals as we really look to focus on wellness and prevention. So I think, the dialogue is definitely changing.
Yeah. H, can I go back to Colleen's last comment on behavioral health?
In 30 seconds or less.
Because it's more than just mental health as some people define it. It's really that entire social safety net for the most vulnerable people in our population around funding for things like just basic care services, Meals on Wheels, prescription drug assistance, care for the elderly. It's more than just, I think, what people traditionally call mental health.
And with that, this one could go 3 hours.
Yeah, true.
Do you want to stay and we'll... but I have to say, for air purposes, I have to say thank you to Dr. Keith Knepp, who's the Vice President at Methodist Medical Center, to Colleen Canaday, who is the President of Advocate Bro-Men in Bloomington Normal, and to Dr. Steve Hippler, who is the Vice President at OSF St. Francis Medical Center. Thank you to all three of you for the stimulating conversation. It was very good. It is the holiday season. We wish you the best of Christmas and New Year's. We'll be back in 1 week with a somewhat related topic. We're going to be talking about compassion next week on that issue. Those small organizations that Dr. Hippler said we need to partner with that are making a difference in providing services to those in need. Have a nice holiday.